Welcome to this targeted oncology presentation in precision medicine called BCMA Targeted Therapy for Relapsed-Refractory Multiple Myeloma. I'm Dr. Ola Landgren, Professor of Medicine, and I'm Chief Attending Physician of the Myeloma Service at Memorial Sloan Kettering Cancer Center in New York City. I'm here with my colleague, Dr. Nina Shah, Associate Professor at University of California in San Francisco. Targeted therapies have really come to the forefront of treatment of cancer. Today we're going to talk about an important therapeutic approach that targets B-cell maturation antigen, or BCMA, which has shown great promise in treating relapsed-refractory multiple myeloma. Several types of BCMA-targeted therapies are currently being investigated, and this represents a potential paradigm-changing advance in precision oncology and drug development for patients with relapsed and refractory myeloma. Thanks for joining us, and let's begin. Welcome, Nina. It's a pleasure having you here today.
Thanks. I'm really happy to be here. Thanks for having me.
So before we start talking about the BCMA-targeted therapies, I would like to start a little bit broader and talk a little bit about the treatment landscape for patients with relapsed refractory myeloma. There's so much going on.
Yeah,
What's
definitely.
your perspective?
I think that there have been more drugs than we've had time to know exactly what to do with them, and I think a clear example of that is daratumumab, which only 3 or 4 years ago was thought to be only a drug for relapsed myeloma, and now we've moved it to the front, and that's opened the way for a lot of other different drugs to be developed in relapsed myeloma, including, as you mentioned, the BCMA targeting agents, as well as other antibody drug conjugates, other modes of targeting BCMA, including CAR-T, BiTE, ADCs, and as well as other non-BCMA small molecule inhibitors, and then repurposing of things like venetoclax.
So in your opinion, what's the biggest unmet clinical need we have in the relapsed setting for myeloma?
I think that we have never been able to cure myeloma in general, right? We've done really well in upfront, and we've extended people's life, the time of progression, the time that they're actually living, but most of that we're doing upfront. We're not doing as much in the relapsed refractory setting, and we know that with each subsequent line of therapy, the rate of response goes down and the time or duration of response goes down. So I think we haven't made as many moves on that time as I'd like to see.
I would agree with that. I think also big picture, I think it's important to emphasize that although there are a lot of issues that we still have, we are dealing with, if you just look big picture, patients with myeloma these days live for a very long time compared to just what we saw around the turn of the century. I think the overall survival used to be around 3 or so years from diagnosis, and today patients here in the United States probably have an expected overall survival of maybe 10, 20 years or something like that.
Yeah, I think you're right, and I think that's made a huge difference where we've really changed myeloma to be a chronic disease that maybe you don't die from, but that you live with. And all of these drugs that have been developed, as time goes on, we're learning how to use them better in better patient populations and allowing them to make a bigger impact on the actual individual myeloma patient's life.
So let's talk about BCMA-directed therapy. So what's the rationale? Why would one think about using BCMA as a drug target in myeloma? Can you talk a little bit about that?
Yeah, so as you mentioned, BCMA stands for B-cell maturation antigen, and it's a protein that is expressed pretty exclusively on plasmablasts and plasma cells, and it's involved in signal for proliferation and activation of the plasma cells. It interacts from its exterior surface on the plasma cell with APRIL and BAFF on effector cells, and as I mentioned before, it's supposed to be involved in proliferation and downstream signaling. The reason it's thought to be a very good target for myeloma is that it's very specific for the plasma cell. So it's actually not found on non-plasma cell or specifically hematopoietic elements, which we always was worried about for cytopenias, et cetera. So it turns out to be a really nice sort of holy grail antigen or target for us to target for things like cellular therapy.
So BCMA is expressed on the plasma cells. Myeloma is a plasma cell disorder. It's not expressed on the other cells. Maybe it's a little bit expressed, but very, very little.
Correct.
What about levels of expression? Is there a need to test individual patients for high or low expression levels on the myeloma cells, or could you talk about that?
Yeah, you know, it's been a confusing situation because in order to know whether high or low BCMA makes a difference, you have to have the right test to do that. And traditionally, we've used things like IHC, and now there are more advanced ways to look at that. But I'd say that all we know from sort of the dirty looks is that whether you have some or a lot of BCMA probably doesn't make a difference. I think you're right, though. We don't know the full extent of which cells may not have BCMA. What do you think about that?
I think all the data, at least the data has been presented and published in different settings, I think has been derived from expression of RNA, and the target we're talking about is a protein.
Right.
So DNA, RNA, protein, that's the chain. So I guess the ultimate test would be probably to do some form of single-cell proteomics,
Yeah.
looking at proteins, and I don't think that has been done yet in myeloma to
Right.
identify potential other proteins and also to study the exact details of how it is expressed on every single cell. And we know that we can achieve deep responses with the cell therapies. We will talk about that in a bit.
Right.
But unfortunately, patients will still continue to relapse.
Right.
So there probably is some more information that we are missing.
Right. It's a great target, but it's not the end-all, be-all yet, because there's room for us to grow. We know that there isn't a plateau on these curves yet. So I'd be interested to see what proteomics will reveal, both between patients, so individual patients may have differences, and within the patient because there's clonal heterogeneity.